representing someone else who was not able to come for this debate, and the slides were made in a hurry. So now, as Dr. Desai told, that radiotherapy cannot be passed on to the next generation because the technology changes. But Dr. Litana Biswas is here, he's myself. I have done my training in cobalt setting. Now I'm doing it in SBRT. So, and actually the training has been from cobalt, actually been interpolated in SBRT. So nothing is lost. It is a continuous process like surgery. For radiotherapy also the process is from the cobalt only we get our knowledge, and that we use for the new technology what we acquire. And about the cost, I can tell you that SBRT and surgery, the cost is same. And maybe the cost is actually less for SBRT. The reason being is, once you get the machine, the running cost is zero. But first, for surgery, each and every patient, you need to have the equipment or usables. And that is the recurring cost for each and every patient. So if you are in a government setup or charitable setup like us, our cost can be as minimal as zero. But for any center, even if it is a government setup, the cost cannot be zero in surgery because there are some recurring costs involved in it. So now when we talk about pancreatic cancer, I completely agree with Dr. Desai that surgery should be the first option. The reason is the outcome is not that good, and most of the patients do recur, and 50% of the patients do recur outside the pancreas. They have a metastasis, and 40 to 50% patients do recur locally. So even after surgery is done. So that it is not a very promising disease to treat. But there is so much of promise with SBRT as a non-invasive procedure in a pancreatic cancer, which is not that good, and it should be considered as a systemic disease with a presentation of a local disease. Now, if you see the local control after Whipple's and complete adjuvant chemo radiation, local failure is around 50%. So surgery may not be the complete answer for many of the patients, and that is the reality. And and another 50% do fail systematically, and so the 5-year survival is not more than 5 to 10%. So that is where such a aggressive surgery like Whipple's may be difficult sometimes. And now, if you see that if it is a R1 resection, means when the margins are positive, which really happens in a situation where pre-op RT is not given, then there is a significant local failures happen. So radiation upfront before surgery means SBRT kind may be useful in having a better local control. And it has been seen in all the studies that median survival is not good. R1 and R2, the outcome is not that great. So SBRT kind in pancreatic cancers before the surgery may have an impact on local control and as well as in surgery and in survival. So this is what is done, and we can see that if this is a study from Beth Israel Hospital, which has shown that if you are giving a SBRT boost before the surgery, then there is a chance of having local control higher compared to surgery alone. So SBRT do have some role in having a better local control in terms of pancreatic cancer, which is operable localized pancreatic cancers. So these are the different studies of RT, chemo RT. Chemo RT may have some benefit in terms of local control, and SBRT, we are not going into that. And if you see the SBRT results, these are the very early results because this is a very old slides, which has seen that if you see the median survival is around 11 months, 12 months, and if you see 1 year survival is around 40%, 10%. So it is varying between 20 to 50% of the patients 1 year survival with this SBRT data, and that is actually with our surgery arm as well. So there may not be too much of difference, but though there is a noted randomized study. But if you compare the SBRT and surgery and see a 1 year follow-up data, there may not be too much of difference in terms of 1 year survival and median survival. I do agree the complication rate may be a real concern with SBRT. It has been reported that 12% chance of having a perforation after SBRT if it is not given appropriately, and that is a real concern, and that is being taken care of with modern kind of SBRT technique. But if you see the surgery arm, there are so much of different kind of complications after this operation, and so if you compare the toxicity, SBRT may have some benefit in terms of surgery. So the potential for SBRT in neuroendocrine tumors sometimes of pancreas, in localized pancreas tumors where the parotid nodes are not involved, and SBRT may be useful in this kind of situations. Now, there is another two things I need to add, that now, because I have not added the slides, very interesting thing has happened in pancreas SBRT. Something called PTV margin has been added. So when we do a SBRT for any, there is something called GTV, means gross disease what we see, and give a small margin to that, 2 mm or 3 mm margin. It has been seen that if you do that for pancreas, then the chance of recurrence is high and margin positive status is high. So what is done now, and the MBBS study that which has been published last year, that with the GTV, what is the gross disease what we see, we give a 3 mm CTV margin, which is really new for SBRT, and then give a PTV margin of another 3 mm. Then chance of margin positivity has come down. So whatever we see in PET scan in pancreatic cancer, maybe it may not give a complete volume, so the margin status is high after the pre-op SBRT in pancreas, and that has been taken care of. So once that is done, and one study is going on with a randomized study between the CTV based SBRT and surgery and SBRT alone, that may give us an answer, and we will not debate again, hopefully in another 2 years' time when this result is going to come. Thank you.
Any rebuttal, Dr. Desai?
I don't think we can have a rebuttal because there is lack of data on both sides. I mean, because there is no comparative study. But I must appreciate him for giving me a fight so fast, because not with pancreas. And second thing I just wanted to tell, as far as the cost analysis, I also own a radiation machine. So I know that it is not a cost effective study. Thank you.
Dr. Datta?
I completely agree with Dr. Desai that some areas now we can't debate because there is no consensus, and everyone who is giving their own data, and we should wait and have a randomized data. What is happening for TOS? We have a randomized data, and now we have a strong evidences for or against whatever. So that is going to come, and pancreatic cancer is such a difficult disease. I think both the surgeons and radiation oncology are really skeptical in go aggressive, and unless until data comes, give a verdict against or for it. Thank you.
Thank you. I think that was an excellent debate and quite a gentlemanly one. So, yes, Dr. Chan.
I think Devnaran, definitely we should get a standing ovation for taking up this matter.